Good evening, everyone, and welcome to the first of the webinars for the month of August. This month is going to be focusing mainly on just how to be a CT surgery PA in various manifestations or permeations. This first time, we're going to be talking about what's called a clinical framework, basically how to approach your thought process and how that extends to verbal communication and written communication, the thought process being your internal communication with yourself. Uh, so we call it the clinical framework. It's going to be a pretty basic lecture, but sometimes it's good to hear basics renewed, especially when you're a little bit further along, because it can re-solidify things. And if you missed anything along the way in the beginning, it can hopefully fill in some gaps. I'll tell a quick story, which is that in the beginning of my career, I was amazed at how experienced clinicians could remember large swaths of patients with such ease when I was having such trouble remembering them. They seem to remember all these things about all these patients. And it kind of has to go along with the development of memory and how that works. There's a somewhat, I'll use the word famous, study where participants were broken into two groups. You had people who were non-chess players, and then you had sort of experienced or master chess players. And experimenters gave them a box of chess pieces and a blank board, and they said, we're going to show pictures of, chess games to you, and we want to, after a few seconds of looking at them, you recreate what you saw. And they had two categories of pictures. One were arrangements of pieces that would commonly happen during a chess game, and then another was just random pieces in positions that wouldn't even make sense, like two kings next to each other, things that weren't even allowed in chess. And what they found was that if you were a non-chess player, if you didn't know the language, you just did equally bad across the board when you tried to recreate the image that was put in front of you for, say, 5 seconds or so. It didn't matter if it was a real scenario or not. But the experts were really good at recreating real situations because they'd seen it before and internalized it. It's sort of like, oh, that's vanilla. Oh, that's chocolate. Oh, that's strawberry. And so they had a language with which they could draw from and work from. Now, if the arrangement was something that was nonsensical, they had a little bit a harder time recreating it, but they still did way better than the novices because they had the basic alphabet, of the pieces. And that's kind of the way running a service is. I don't memorize every detail about every patient. You have certain arrangements of pieces on the board. So you have a pneumonia picture in your head. You know that someone's going to be short of breath. Maybe they saw a PCP. Maybe they were given some antibiotics that didn't work. They have an infiltrate on X-ray. They're hypoxic. They have sputum production. They have fever. They have a white count. And now they're presenting to you in early stages of sepsis and hypotension. All of those details are a part of a picture that's already pre-memorized. And all you need to do is take that picture and modify and tweak the little individual things that are unique to this particular patient, but you have that basis to draw from. Um, and that's what I call the framework. And the framework extends to all sorts of things. And that's really how an experienced provider can manage a large service pretty easily because you can chunk things. You can remember this is one thing. I have pneumonia, I have sepsis, I have acute coronary syndrome, and that represents a whole arrangement of pieces on the board that with one word, you know all of this about a particular patient, and you just have to tweak small little things. So we're going to be talking about that. We're going to be talking about the framework. When we think about a framework of how to think about our patients, I would recommend, at least what I do, the best ways to go with a system-based approach, meaning, different physiologic systems within the body. Some people don't like that, and they say that, you create silos and you think in categories only. To that, I would say you don't understand how to use a system-based approach because one of the steps at looking at the systems is saying, well, where is their overlap and how do they interact with each other? And so that sort of argument, I think, is a little bit nullified. but you always want to put the most relevant system first, right? If you're a colorectal surgeon, you shouldn't be talking about neuro first. You should be talking about colorectal first. And as cardiac surgery PAs, we should be talking about the heart first, right? It just makes sense. Some people will do this, oh, I have to do a head to toe approach. That's how I'm going to organize myself. And that's a way of organizing. I don't think it's a very good way of organizing because people are going to go from head to toe in slightly different ways. And what you want to do is you want everyone to know what everyone else is going to say. You want everyone lined up. You want everyone on the same team. I want to know, okay, you're going to say pulmonary next, you're going to say GI next, that type of a thing. So that I'm not worried about playing catch up and adjusting my thinking to where you are in your presentation. I'm right there on the same page with you. So the most relevant system, I would argue, should be first. If you want to lose confidence of your collaborating physician, have a cardiac surgery patient, and then the first thing that you talk to them about is their bowel regimen, right? They're going to be like, this person doesn't, they don't have their priorities in the right spot, right? So most relevant system first, cardiac. And then I would say the vital systems should be given high priority, right? And by vital systems, what I mean is that, if you have a problem with GI, okay, yeah, a problem in your GI system can kill you, but it's unlikely to kill you within the next 5 minutes, right? Whereas a vital system, you have a problem with cardiac, that can kill you within 5 minutes if it's the right problem, right? And so the more time sensitive, more volatile ones should be up front. And so I will usually organize cardiac, pulmonary, renal, right? CPR. And I would generally say if you don't have those systems stable, neuro is a quick, one below that that's close sometimes. If you don't have your CPR, then you probably need to be in an ICU if you don't have those systems in a stable place, right? And so by vital systems, I would say address those first. If you don't have airway breathing and circulation, you're an ACLS patient at that point. It just so happens our most important system, cardiac, is also one of these vital systems. So it works out pretty well. Generally speaking, when I have a patient in the ICU, we'll present them with cardiac issues first, pulmonary, and then renal, because those systems are so tied together and relate to the stability of the patient. Once we've addressed those things, gotten those initial high acuity problems under control, you can take your time and go through and talk about GI issues and bowel regimens and things like that, and eventually get to neuro and talk about pain control. Sometimes, again, like I said, neuro can rank a little bit higher on things, especially if they have a specific neuro injury diagnosis. But if their main neuro problem is expected pain control, then you're pretty much fine. So there are a lot of systems. This is one way to break it up, and the list can be long and obnoxiously exhaustive. So we do group somewhat like systems together to kind of make it more manageable. But generally speaking, we'll have a cardiac system first, pulmonary and HENT we put together. If you think about it, if you're thinking about a trach, if you're thinking about upper airway type issues, there's a lot of overlap and synergy between your upper airway and your lower airway. So it's essentially putting those two together. Same thing with renal and GU, putting it together. If you think your renal system is what, filters and your blood and makes your urine, and your GU is more about what stores and then excretes the urine. So the two kind of go together. GI nutrition, hematology and oncology, endocrine and rheumatologic, they don't necessarily go together in the sense that, they're tied together, but they're both sort of abstract physiologic systems. Vascular, ID immune, neuro and psych, musculoskeletal and orthopedic, and MSK is musculoskeletal. It's not miscellaneous. A pet peeve I personally have is there's no such thing as a miscellaneous system, right? At the end of everyone's notes, they're like miscellaneous, and that's where they put their GI prophylaxis. That's where they put their VTE prophylaxis. I would argue the GI prophylaxis should go under GI nutrition, the VTE should go under HEMOC, and those types of things. There is a place for things that we do, and you want to relate it to the overall governing physiology, not just label it miscellaneous. It seems a little arbitrary and uneducated. A dermatologic wound, and then other. I would never put other as a system, but what I mean by that is that there are systems that are unique to patients that are only should be included if the patient has an issue with it. Like if there's an ophthalmologic issue, well, then throw that system in there. Or if there's a gynecologic obstetric, well, then throw that system in there. But I certainly wouldn't have a gynecologic system in a man, right? Doesn't make any sense. So you want to break things up into systems. Now, once you have your system, within that system, you have to create a problem list. And then for each individual problem, there's two categories of things that you can do for people. You can either do diagnostic interventions or therapeutic interventions. And almost anything that you can think of, I can slot into one of those two main categories. You're either going to do something that gathers more information so that you can further refine or define or identify a new problem, or you're going to do some sort of a treatment and take an action within that problem. And sometimes those actions are medicinal, sometimes those actions are mechanical, sometimes those actions are social. But basically, anything that you do for any particular problem can fall under those two categories. And we're going to start building our problem list within our systems. So there are certain things that are inherent to our type of patient, certain risks and certain known problems that are frequent enough that we identify them ahead of time and prophylax against them. And it's is going to be something that a list that every is attached to every patient that we interact with, at least our types of patients. So for pulmonary HENT, all of our patients, assuming that they're going through surgery of some type of CABG, a valve, an aorta, something like that, are going to have atelectasis risk post-op. And that's something that you need to mitigate against with activity and incentive spirometry and pulmonary toilet, things like that. All of our patients are going to have a hospital-acquired or if they're on a vent for a long time, ventilator-acquired pneumonia risk. And there are actions that are taken. The head of bed should be elevated to a certain degree. The airway secretion should be managed to a certain degree. You need to do diagnostic modalities, as in checking chest x-rays at appropriate intervals to monitor for the onset of this, and as well as prophylax or take therapeutic interventions if it does occur. For GU and renal, all of our patients are going to have electrolyte imbalance risk. There's a significant amount of fluid shifting that goes on during the stress reaction. Stress reaction is a result of any type of trauma that occurs to the body, and surgery is just a very organized, somewhat, I'll use the word controlled, form of trauma. And so fluid gets shifted from different spaces, and we're also giving medications oftentimes to help diurese patients. And although the goal is to get rid of fluid, you inadvertently necessarily get rid of electrolytes in different concentrations as well. And so that needs to be monitored for and taken into account. For GI nutrition, again, most of our patients are going to be at risk for stress ulcer formation. Of the types of trauma that you can go through, the really significant ones are burn, prolonged ventilator use, and cardiopulmonary bypass. And cardiopulmonary bypass is really high up there with the most significant stresses that your body can go under. All of our patients are going to be at risk for an ileus. They're in bed, they're on narcotics, they're immobilized, they're usually NPO for a time period, and that needs to be addressed and mitigated for. Nausea risk, and then protein calorie malnutrition. If you're NPO, it's a fancy way of saying malnourishment. All things that you need to take into consideration. And the thing is that one day of being NPO is not so bad, but at a certain point, um, you cross a threshold where the risk of your protein calorie malnutrition, the problems associated with that become greater than the interventions that would mitigate giving them some type of nutrition, whether it's tube feeds or whether it's TPN or something like that. And not only do you have to worry about, giving the actual nutrition, but the mechanical modality that delivers it, whether that be a Dobhoff, whether that be a central line. Central lines can get infections. Dobhoffs can go into lungs and cause pneumothoraces, all sorts of stuff. For heme and onc, Our patients are going to be at risk for venous thromboembolism, again, because of stasis, coagulation derangements, possible trauma. And then acute blood loss anemia, which is a fancy way of saying you lost blood. Some of these, you might look at these terms and you'd say, oh, I've never used the phrase protein, calorie, malnutrition. I've never used the phrase acute blood loss anemia. They're sort of billing terms. You can't just say anemia. You have to specify specifically what it is and if you want to get reimbursed for what it is you're doing. And that is a fair and correct thing to be doing. You have to meet the requests of the billers and how you describe things. Stress, hyperglycemia, and really it should say glucose imbalance because we care about hypoglycemia too. Is a part of the stress reaction as well and needs to be anticipated and treated. Vascular access necessity, you're either going to need peripheral access or central access. And many of our patients, it's usually, especially early on, going to be central access. For ID and immune, most of our patients are going to have a reactive leukocytosis during their immediate stress period, or they may have a systemic inflammatory response. And there is, diagnostic criteria for that patients go in and out of. Surgical wound infection risk, and we prophylax against that with perioperative antibiotics and good wound care, MRSA, MSSA colonization specifically, and then pain control for under neuro and psych, and then under musculoskeletal deconditioned state or acute muscle weakness. And then for your dermatologic and wound incision issues, and then decubitus risk. And decubitus is not just on your sacrum. You can have them on the occiput, the back of your head, on your heels. There's all sorts of places that these things can happen and can be a problem. Now, you'll see a lot of times people will give the diagnosis as the treatment. And what I would say is that, you're saying someone might say something to the effect that I'm giving IV antibiotics, and they're saying empiric antibiotics is the diagnosis. And it's like, it's not really the diagnosis. That's what you're doing. You're giving empiric antibiotics to mitigate a risk associated that the patient's giving or that the patient has. You're giving a PPI ulcer prophylaxis is not your diagnosis. That's your treatment for stress ulcer risk. It's sort of like when a patient is on, let's say they have atrial fibrillation, and they'll say, I'm on Coumadin for atrial fibrillation. You're not really on Coumadin for atrial fibrillation. Coumadin is going to do nothing for the atrial fibrillation risk or for the for the irregular rhythm. What it's doing is mitigating the thromboembolic risk associated with atrial fibrillation. So what you're really treating is the risk of a stroke. A thromboembolic risk is what you're prophylaxing against. And so it's important to understand the difference between treatments and problems. And then the other thing is primary diagnoses and secondary diagnoses. Someone comes in and I say, what's wrong with the patient? And I'm told, well, they're in shock. And it's like, that's a secondary diagnosis. Like a lot of things can put you in shock. Is the patient bleeding into their gut, right? And do they have hemorrhagic shock? That's, the bleed would be the primary diagnosis. Shock is the secondary state. Or do they have an occlusion in one of the coronary arteries and they're in cardiogenic shock? Their acute coronary syndrome is the primary diagnosis. The shock is the secondary diagnosis. The other example of that is ARDS. Other patients in ARDS, it's like, well, what are you talking about? Were they in a car accident and the stress from that has put them in ARDS? Do they have pancreatitis because they're a raging alcoholic and it's just blossomed into the latest pancreatitis acute episode, and now they have ARDS as a result of that? Those are two: car accident and acute alcoholism with associated decompensation and pancreatitis are two totally different patients, right? But they're both ARDS. So you have to be careful of primary diagnoses and secondary diagnoses. And it's okay to talk about the secondary diagnosis, ARDS, that's important to take care of. and cardiogenic shock that's important to take care of, but you got to give people context. Even something like, I'll hear someone say, "Oh, they had a CABG." I'm like, well, that doesn't really help me too much. I know they had an operation, but I don't know why. Are they a young 25-year-old who had an anomalous coronary that needed to be fixed? Or are they like an 80-year-old who had atherosclerotic disease? Those two totally different people, but they both had cabbages, right? So you want to be accurate in what you're talking about. Now, you might say, you've been talking a lot about risk, but this list could go on forever. You're right, right? You're at risk for UTIs, you're at risk for this, you're at risk for that. Um, you know, these are the things that are frequent enough that they're known problems that if you don't actively prophylax, you're going to develop a problem. There are other things that you might be at risk for. They might happen, but they're not frequent to the same degree that they need active prophylaxis. They just need monitored vigilance uh, so that they can be identified when they do occur. But in the meantime, good general nursing care and good vigilant medical practice is the prophylaxis for the risk of all the other myriad of things that can possibly happen to patients. So there are certain diagnoses, and hopefully what you're seeing is we're building the chessboard here, right? That go along with specific things that we do. So most of our patients will go on cardiopulmonary bypass. And there are diagnoses associated with that. A lot of patients will have a post-cardiotomy low cardiac output syndrome, which is a sort of a form of shock that is a diagnosis of exclusion, meaning that they don't have any other reason to have an identified cardiogenic shock other than the fact that they had a bypass run. As well, you can have post-cardiopulmonary bypass vasoplegia, right? And so just by going on to bypass, these are two things that we would be added to my problem list. Now, not every patient manifests these problems every time, but it's frequent enough that I would say most patients express some degree of this, at least for a day or so sometimes. For CABG cases, the revascularization process can put patients at risk for dysrhythmia. About a third of patients will go into atrial fibrillation. Some people believe in amyoprophylaxis, other people don't. But it is a known risk, and we do put people on beta blockers for cardioprotection in the postoperative period. And then, your grafts can go down. The fact is that you have coronary artery bypass grafting thrombosis risk that occurs after a procedure. And we treat that with either aspirin or Plavix or both or some form of anticoagulation, if not antiplatelet therapy. But that is a risk. It's something that needs to be mitigated against and monitored for as appropriately and then treated if it develops. For valve cases, similarly, you have a bioprosthetic or a mechanical valve associated thromboembolic risk as well, which is why the patients, depending on what type of valve they have and what your practice is, will be treated appropriately to mitigate this risk. Now, there are certain things that, in theory, it's at risk for happening. Um, we don't prophylax against them, but we want to make sure we're vigilant in identifying them. Paravalvular leaks is something that's unique to valve cases, certain types of valve cases. You should know that while you're in the operating room, and it's not something that should be identified in the postoperative period. That should be seen intra-op and hopefully fixed intra-op. But bioprosthetic valve endocarditis is a risk that they're going to carry, the rest of the lifetime that they have this particular valve in place. But you're not necessarily going to give them lifelong antibiotics in certain instances, in certain procedures, in certain at-risk patients. They might get peri-procedural antibiotics depending on things, but it's something to know and think about. The transplant realm is unique. I practice transplant surgery. I realize not everyone does, but there is a whole host of things that go along with transplant surgery. These patients are at risk for a lot of extra diagnoses because of the significant immunosuppression and because of the fact that they now have an organ that's kind of not really theirs. in their body and is creating a constant reaction. So they can have rejection risks, and the rejection can be hyperacute, acute, subacute, chronic. And a lot of that depends on a lot of things that is beyond the scope of this talk. But it's important to think about. Chronic graft vasculopathy is the very slow form of rejection that occurs over time. It's one of the reasons why transplants only last so long, half-life being around 10 years. And the type of coronary artery disease, this graft vasculopathy that occurs, it's a different coronary artery disease than the usual atherosclerotic that we see and we bypass all the time. Usually, there's a area of stenosis and then a distal target, right? You need to have a place to sew a graft to. That's what, normal atherosclerotic disease looks like. Chronic graft vasculopathy is a slow and gradual taper, such that the vessel for the whole length of it kind of becomes sort of like a shoestring. So there's no target to sew to. So there's no kind of such thing as revascularization for chronic graft vasculopathy. If it gets bad enough and the heart becomes compromised and the function's going down, blah, 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 you're looking at retransplantation, which the rate for that is not particularly good. Um, because the patients are on steroids, they're at risk for thrush, depending on, this should say CMV, not CMR. Depending on their titers for different viruses, they can be at risk for CMV, EBV, they get at risk for toxoplasmosis, PCP, a risk, again, all because of immunosuppression. And it depends a little bit on what the donor brings to the table, a little bit what the recipient brings to the table. Um, Also, because they're getting an organ from another person, if the donor is infected, that becomes a risk. And sometimes the donor infections don't really be fully optimized or not optimized, identified till like 3 to 5 days after transplantation, because cultures take a certain amount of time sometimes. Sometimes patients can be at risk for what's called a PTLD, or post-transplant lymphoproliferative disorder. It's basically a type of lymphoma that happens specifically in immunosuppressed patients. The other type of cancer that transplant patients are really at risk for is skin cancers. Now, you're not going to see this in the postoperative period, but if you get a transplant patient that's readmitted years down the road, they'd be in the window of being at risk for that. And as well, they can have what's called PRES, a posterior reversible encephalopathic syndrome, which is a result of some of the transplant medications, specifically the calcineurin inhibitors, right? And you can see how we put the problems within the relevant systems. So for MCS devices, mechanical circulatory support, certainly you can have pump infections, which is a problem. Um, for hem-onc, all of these patients are going to be at risk for pump thrombosis that can clot off the pump, and they're all at risk for hemolysis. The devices are all going to damage your blood, specifically your platelets, and give you an acquired von Willebrand type syndrome, and will consume various degrees or amounts of your clotting factors. And hemolysis, if significant enough, can lead to a type of myoglobinuria, rhabdomyolysis, kidney type failure, and can be a problem. Um, with the mechanical support devices that are implantable and durable, like the HeartMates or the Briovacs or things like that, you can have driveline site infections, which is the driveline is the power source that exits the abdomen. And again, this is an example of phraseology that the billing companies want us to use, which is intentional artificial orifice of the driveline site. That's a fancy way of saying where the driveline exits the body, but if you want it recognized properly, that's how they refer to it, an intentional artificial orifice. Um, so again, these patients, all of them, if they have devices long enough, are going to get colonized. And eventually, if it goes on long enough and that bacterial burden becomes significant enough, it can translate into an infection. And a lot of them will need sometimes lifelong antibiotic suppression, right? So then patients can have common complications, right? So you're going through your postoperative period. Patients, it's very common to have systemic hypertension in the sort of transplant type realm that I work in. A lot of them have pulmonary hypertension as well. Like I talked about a third of patients are going to go into some type of cardiac dysrhythmia. The most common is going to be atrial fibrillation or flutter, plus or minus a rapid ventricular rate associated with that. For GU and renal, a lot of patients get fluid overloaded, and when they do, they end up with a hypotonic, hypervolemic hyponatremia, which is probably of the sodium imbalance types, the most common one that we're probably going to see. A lot of them will have organic metabolic lactic acidosis buildup or inorganic metabolic acidoses. And the organic acidoses, it's the addition of an organic acid, which is a carbon-based molecule, or an inorganic metabolic acidosis is usually a bicarbonate deficit. A lot of them can have acute tubular necrosis, acute kidney injury. Um, for GI nutrition, we'll see a lot of elevated LFTs as a result of sometimes shock liver type states, sometimes because of medications, sometimes because of acalculous cholecystitis. Depends on how sick the patient is. But they may have hyperbilirubinemia or hyperammonemia. Um, for hematology, oncology, thrombocytopenia is very common, and a lot of things contribute to this. Consumption is one. The platelets get used up because they're trying to stop bleeding because we create bleeding with surgery. There's platelet destruction, especially if you have a circulatory support device. They just get beat up. And then there's dilution, where the amount of platelets you do have get diluted through non-platelet volume, be that crystalloid or just packed cells, or you're not necessarily giving whole blood. Um, that's why if you're doing mass transfusion, there's a recommendation that, for every certain amount of packed cells you give, you should be giving some FFP and some platelets along with it to make sure that in essence you're restoring that whole blood type profile. Otherwise, you're going to dilute things out. So dilution, consumption, and destruction. Along with that, then you can also have other reasons for low platelets like HIT, and you need to be aware of that. For endocrine and rheum, we see a lot of absolute or relative adrenal insufficiency. And again, depends on how sick your patients are. For neuro and psych, we see quite a bit of delirium, anxiety, and depression, and a good amount of muscle spasm too, right? And so those are all things. One of the things that often holds people up going home is the fact that a lot of clinicians don't realize that treatments become problems, right? And they see what they're doing as a treatment as just something that's good and not something that's also bad at the same time. A lot of things that we do become problems. And so the rule I say is if something is being intervened upon to the patient that is not the way God made that patient, then it's a problem, right? So we have chest tubes that are in place, and they're great. They give us diagnostic information about what the output is and if they're bleeding, and it prevents tamponade. But it's a problem because you can't go home with it. And you might argue, it's like, yeah, well, they have certain long-term, Pleurex catheters or whatever. That's the exception. But even still, you don't just magically send someone home with a Pleurex. You have to put it in, and then you have to give them teaching so that they know how to care for it. So either way, it's a problem that they can't go home with. Your pacer wires, great. They give you diagnostic information. You can do an atrial EKG. You can treat a patient. You can pace them if they're, asystolic or whatever. Um, but you shouldn't be going home with them. That's an issue. And if you do need to go home with pacer wires, then you probably need an implantable device. But either way, they got to go. Same thing with your pulmonary or pleural chest tubes. If you're intubated, intubation's a problem, right? And so, yeah, are there long-term care facilities that take vented patients? Sure, great. But intubation long-term can lead to tracheomalacia. It increases your risk of pneumonia. There's a risk that at any moment the airway can be removed, right? And you have loss of an airway. And then you could say, well, I'll just transition them to a trach. Well, okay, they need trach supplies, they need teaching, they need, yes, you can go home with the trach, but not magically the next day. Same thing with supplemental oxygen, right? So if someone's clearly not going to get off oxygen, well, they need to have oxygen set up so that they could go home, right? So on the one hand, oxygen's a treatment. Great. Yeah, I have some acute hypoxia going on. Let's take care of this. But if you're either not going to actively attempt to wean them off, or if you've attempted to and you've failed, you need to set something up ahead of time. Foleys are a problem. Great. They give us diagnostic information about urine output. They prevent people from soiling themselves. They prevent, some urine getting into wounds, things like that. Um, but if you're going to go home with the Foley, you need leg bag teaching, you need follow up with urology, and that takes logistics. If you identify that as a problem the day that they're going home, they're not going home that day, right? They're going to go home the next day after you've taken care of what you should have taken care of, like last week. So treatments become problems. Same thing with feeding tubes. Same thing with ostomies. They need ostomy supply. They need ostomy teaching. They probably need an ostomy support group, right? Vascular lines. Again, you can have a pick like a long-term IV put in, but you have to anticipate this. You're not going to send someone home with a cordis. It's a problem. And then same thing with their wounds, right? You're going to need dressings and supplies. When are the staples going to come out? When are the sutures going to come out, right? We're the actual surgical team. If we're not the ones that are thinking of this and taking care of this, then quite frankly, no one is. Or if they do, it's not going to be likely appropriate. So treatments also become problems, right? And so we're slowly building up the map of what our patient looks like. Now, so far, we've been talking about things that are inherent to our surgical patients, but patients come in with their own histories, right? And they have primary care physicians that have been following them for a long time, and they can have chronic problems and they can have acute problems, and they collect these diagnoses over time. And so, where do you go to find these things? Because not every patient is a really good historian, and not every patient can even give a history at all if they're sedated or intubated. So where are you going to look for these things? Well, acute diagnoses, you could get a lot from your vital signs, a lot from your physical exam, a lot from your lab values. You get a whole boatload of diagnoses from there. Acute and chronic diagnoses, again, you can get from physical exam and lab values. Most of your chronic diagnoses, past medical history, surgical history, social history, family history, medications. Like there is an endless amount of people who believe that they don't have high cholesterol because they're on a statin. And I can't tell you the number of times I say, "Oh, I see you're on Lipitor. You have high cholesterol." And they're like, "Not anymore. I'm on Lipitor." It's like, okay, it doesn't work that way. But people will either omit or even deny diagnoses that if you look at your medication list, clearly they have. And so you want to go through and collect as much of this as you can. And, the quote I remember from PA school was 80% of your diagnoses should come from your history and physical. And then lab values, diagnostic studies, those things are confirmatory or refining of your diagnoses, of your clinical suspicion. You don't want to do the shotgun approach of I will order every lab value and every test. That's a good way to exhaust the resources of your system, right? You want to be responsible stewards for the care of your patient specifically, but also of the overall health system, at large. So let's keep going here. So let's go through a bit of a sample patient, and we'll pick the most complicated patient we can think of. Let's take a patient who had an implantable mechanical circulatory support device, a VAD, and then had a heart transplant, and is now also ECMO supported. And let's see if we can build up a diagnosis list or a problem list, and then develop appropriate diagnostic and treatment modalities for the patient. So let's go over here and see. For cardiac, they're likely to have low cardiac output syndrome and post-cardiopulmonary bypass vasoplegia. They're going to have chest tubes. They used to have an ICD or a permanent pacemaker. It's now removed, right? They've got a JP drain at that site. They probably have A and V pacer wires. If they're a transplant, they're at risk for something called a relative associated or a transplant associated relative bradycardia. The idea is that your resting heart rate is suppressed. Um, such that when you become tachycardic, that suppression is a little bit relieved. And so the resting heart rate for a transplant patient should be around like 100 to 110. And so if they're in the 70s or something, that's not good. They should be going faster than that. The things that stimulate your heart to beat at different rates are your nervous system. You have innervation to your heart, and then you have your catecholamines. You have an endocrine effect on your heart with epinephrine. And so the immediate system, the one that allows you to stand up quickly and not get orthostatic, is the innervation to your heart. And then the more longer term adaptation, minutes rather than seconds, is your catecholamines. And so when you do a heart transplant, you cut those nerves. We're not reanastomosing any nerves, right? And so they lose that ability. They lose that acute ability to adjust for the heart rate. That's why when a transplant patient does physical therapy, they have to kind of pitter patter their feet and get their catecholamines going before they stand up. Otherwise, they can get orthostatic. Um, so they only have one system that sort of supports their heart rate, and it's going to be their catecholamines, which is why if you give a transplant patient a beta blocker, in theory, you can make them profoundly bradycardic and kill them. And so what you're doing is that they have their nerves removed, and now you're removing their catecholamines, and now their heart has no support system to maintain their heart rate. Um, so you might see a transplant patient on a beta blocker, but I would say it's the transplant cardiologist that should be putting that on, not us. So they can be at risk relative associated bradycardia. They're probably going to have systemic hypertension, pulmonary hypertension, ID immune. Again, all of the things inherent to immunosuppression and the fact that they have a foreign organ in their body. Pulmonary HENT, they're at risk for atelectasis, as we talked about. They're intubated, they have pulmonary chest tubes, their sodium's deranged, their kidneys are off, they have a lactic acidosis, their electrolytes are out of whack, and they got a Foley in place. Their NPO, they're at risk for ulcers and bleeding. They probably have a tube feed in because this is going to be a slow process and they're not going to be eating for some time. They're going to have an ileus. They may have nausea type issues. Their liver may have taken a hit. They're definitely going to be anemic, thrombocytopenic. They're going to be at risk for DVTs. They're on ECMO, so they have a risk of clotting the pump, and the pump is going to cause hemolysis to varying degrees. They're at risk for glucose imbalance. They may have hypothyroidism, let's say, in this particular patient. They need vascular access, and so these are the lines that they have. You want to keep track of your lines, right? If you're not keeping track of how old your lines are, then again, no one is. And you could say, oh, well, nursing has a protocol where they monitor these things. Trust but verify, right? You should be keeping track, Swan day number 3, right radial A line day number 5. And each day you want to consider, is it really necessary that we have this today? All right. Or is it just there because it's there? And should it be taken out? For neuro, again, incisional pain control, they may have an element of delirium, anxiety, or depression. They're going to be deconditioned, have acute muscle weakness. They may have muscle spasm. They're going to have a dressing that has an issue, and they have an old intentional artificial orifice that needs to be addressed, now has a drain there, and they're at risk for decubitus. And so, what are we going to do? Not every diagnosis or problem that you have needs a diagnostic study, right? Some things it's like we're aware of them, plans in place. I don't need to check anything for a while. But then some things need daily checks. Some things need hourly checks. Some things need continuous monitoring, like an EKG or an ECG monitor, something like that, telemetry. Um, so for your post-cardiac cardiotomy, low cardiac output syndrome, well, you're probably going to be monitoring their cardiac output index, SpO2, and lactate, right? And you're probably going to be doing this, if not continuous, at least 1 hour. And they may need like a TTE every day, every other day, every few days, anytime you anticipate a significant change, something like that. For your vasoplegia, your SVR, and your MAP, and again, you're going to be following this and trending and titrating your inotropes and your vasopressors for these two particular problems. For your chest tubes, you're going to be looking at the output at least every hour, especially early on. As the days go on, it might become every shift, something like that, but you're probably going to be checking a chest x-ray each day. right? Same thing with the JP drain, pacer wires. You're probably going to interrogate them, making sure that they're working, making sure that the sensitivity and the output voltage is set correctly. For your systemic hypertension, you're monitoring your blood pressure, right? For your pulmonary hypertension, you're monitoring your PVR, your transpulmonary gradient, and seeing how they respond to the treatment modality. So if it's Flolan or it's inhaled nitric oxide, something like that. For your reactive leukocytosis, you're probably checking a CBC, you're monitoring their temperature. For the transplant patients, they get biopsies weekly to monitor for rejection, once every week for the first month, and then every 2 weeks, and then every month, and then every 3 months, things like that. And yeah, sometimes transplant patients can be in the hospital for like a year post-op if they have a bad enough course, in which case that schedule is something you need to be aware of, right? The donor infection source, you got to follow up on the donor cultures. And sometimes it takes a few days, 3 to 5 days for them to come back for final. Um, for your intubated state, again, you want to interrogate the ventilator, make sure that the settings are right, make sure that there's good patient ventilator synchrony. You want to be checking the chest x-ray, make sure your ET tube is in the correct place. You are going to have an oxygen monitor on, saturation, oxygen saturation. There's been a move within the last few years to also have end tidal CO2 continuously monitored. You might need ABGs every now and then to kind of correlate what's going on. Uh, Pulmonary chest tubes, again, same thing as the mean chest tubes. You're monitoring it more frequently in the beginning and then a little bit less so as time goes on, right? GU and renal, you're monitoring your weights, you're monitoring your ins and outs, you're looking at your urine output and your Foley. For your kidney function, looking at your BUN and your creatinine, your sodium, your other electrolytes. For your acidosis, looking at your lactate and your bicarbonate level. For your GI nutrition, yeah, maybe you're checking albumin, prealbumin, things like that, LFTs, trending your LFTs. For your heme, again, your acute blood loss anemia, you're checking H and H's. And so now this is sort of paradoxical because like you can make someone anemic through phlebotomy. Too much blood draws is not a good thing. And so some patients, what we'll do is we'll limit blood draws or we'll use pediatric tubes specifically so that less blood is drawn. Same thing with platelets, monitoring platelet level. And then for hemolysis risk, the hemolysis panel is usually a free hemoglobin, a lactate dehydrogenase, and a haptoglobin level. And if you really are suspicious, you could check a myoglobin level within the urine as well. But usually you'll see T-colored urine, and that will pretty much clue you into that. For stress hyperglycemia, there's going to be protocols for capillary blood glucose levels and those types of things. And then for monitoring for decubitus risk, you got to turn and reposition and actually look at your patients and examine them. And you know the idea is coming from trauma. When you examine a trauma patient, you got to strip them down naked, right? And you got to see every inch of them, and that includes rolling them over and seeing their back, right? Because there's a whole bunch of instances of, someone's like laying on a knife, right? Think of a decubitus as like a patient's laying on the knife, essentially. If you let that decubitus sit there and fester and get infected, and they can become septic from it and can be a source ultimately that kills the patient. So you want to go through, you have your systems, you develop your problem list, and then you think about what you're going to do diagnostically for those particular problems, if anything, right? And then you need to move on to what your treatment is going to be, right? And there's different treatments for different problems. For the low cardiac output syndrome, well, this particular patient's on VA ECMO, like we talked about, but they may also be on various inotropes. For the vasoplegia, they may be on vasopressors. For the chest tubes, it's hooked up to continuous negative suction, right? For their wires, maybe they're not being used, but you want to have a plan in place. Like, well, we're going to keep them in place, but they have to be cut because they were sewn in place in such a way that if you pull them, you're going to cause bleeding, right? So some wires can be pulled, some wires can't, right, depending on the situation. You want to know what your setting is on your pacer wires as a backup. This way, if you do need to turn it on, you can put it on. What are you giving them for PRN hypertension? Make sure that it makes sense. Same thing with their pulmonary hypertension, and go through and build a plan slowly, right? What are you going to do? Some things you're going to do stuff for, some things you're not, right? So their protein calorie malnutrition risk, well, their NPO, they got some tube feeds going. Ulcer risk, they have some protonics going, right? For bowel, or their ileus risk, they have a bowel regimen, right? A lot of times people will put bowel regimen as the problem. They're like, oh, bowel regimen. It's like, that's the treatment. The problem is the ileus risk that they're doing. Oftentimes people won't consider risk as a diagnosis, although hopefully you could see it's a massive form of diagnostic labeling for your patients and is helpful to think of it that way. Your lines, do we want to keep it or do we want to get rid of it, right? You got to think about all those things. Pain control, what are you giving for breakthrough? What are you giving for maintenance? That type of stuff. Um, and you want to go through and build your plan. That's the framework, the clinical framework. Now, this is super detailed, right? But it's details that kills patients in the ICU, right? So every now and then there's a big catastrophic event, but that tends to be on the rarer side. Really, what kills most patients in the ICU is the accumulation of small little details. You neglect the fact that they're now 7 days NPO because you haven't been paying attention. You neglect the fact that their swan is now 14 days old because you haven't been paying attention. You neglect the fact that they're not on a bowel regimen and they haven't had a bowel movement in 5 days. You neglect the fact that the patient doesn't have their head of bed elevated and they don't have good pulmonary toilet and they're developing a pneumonia. It's this little death by a thousand cuts type situation or a thousand tiny little knives. And eventually they get a foothold, and all these little problems come together and create a big bad situation where the patient then doesn't survive. So you want to be detail oriented, and you want to be vigilant. And the thing is that no one can remember all of these little details. This is too much. This is too much for one patient. This is only one patient. You might have 10 patients that look something like this, right? And so unless you have a framework, a way of understanding patients, a chessboard in mind, right? That you can have a starting point such that you only have to remember the outstanding little details because everything else is so rehearsed and gone over in your head that it's sort of internalized. And you walk into a room and you can go check, 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 and work your way down this list very quickly in your head. That's kind of what you want to be able to achieve. Now, so other data sources, we talked about patient history, 24-hour events, what happened over the last 24 hours as you're going from day to day. Because, so far we've talked about like an initial plan building. How do you modify the plan day to day? Physical exam, vital signs, hemodynamic data, um, any equipment physical exam. And what I mean by that is that think of things that are attached to the patient that are keeping the patient alive as external extensions of those organs, right? So a ventilator is an external extension of the patient's lungs. An ECMO circuit is an external extension of the patient's heart. A CRT circuit is an external extension of the patient's kidneys, right? It's just as much an organ for that patient as their actual organ. In fact, in this acute situation, it might be more of an organ, right? And so the same way that you would examine a patient and say, oh, these particular findings fall under this system, you should be examining this equipment and saying, oh, this is the way it's supposed to look. You want to know what the alarms values are set at, and are they set appropriately? You want to look at what the actual settings on the device are for care and delivery of the patient. And you want to see not only what are they set, but what's actually happening, right? You can have a ventilator set for a tidal volume of X, but the patient might not get X, right? They might get less than X because their compliance is off. So you kind of have to figure those things out. Laboratory values, radiology, ins and outs, med reconciliation should be done every shift that you come on, every patient, anytime that there's a change in patient status or location, right? They go to the OR, they come back from the OR, you need to med reconcile, right? I can't tell you the number of times that people feel that it is unnecessary or annoying or too arduous to do med reconciliation. And what happens is a patient was on a beta blocker appropriately preoperative before a CABG, and now they have a post-cardiotomy low cardiac output syndrome, and they're on epi, and no one stopped the beta blocker. And so they're on a beta blocker and epi at the same time, which makes no sense, right? It's chasing your tail. Or you have a patient who had acute coronary syndrome and was appropriately on a heparin drip beforehand, and it's now post-op and they're bleeding, but no one stopped the pre-op orders. And so now they're bleeding and they're on heparin, right? And it happens all the time. And you might be like, oh no, the nurses will catch it. It's like, well, not everyone is created equal, right? There are good and bad doctors, there are good and bad PAs, there are good and bad nurses. Sometimes you're going to get this super experienced, hyper vigilant, awesome nurse who's going to be like, yo, dude, this patient's on a beta blocker and some heparin, and they're also on epi and they're bleeding. You want to do something about this? And then you might have a nurse that's maybe not as experienced, and they're just going to be like, okay, and they're just gonna have it on both, and that's the way it is. And then you'll come in the morning and get yelled at appropriately. And so things to think about. Past 24-hour events and colleague progress notes. You need to read the chart, go through, see everything. And then, the last thing over here, basically, I'm not going to talk about this too much. We're running out of time. We only have 5 minutes left. Um, when you go through and you present your patients, as long as you keep this framework in mind, do the most vital system, most important, most relevant system first, cardiac, right? Do your vital systems next, CPR, cardiac, pulmonary, renal. Go through in an organized way, right? Do it the same time every way. Find out what, your surgeon likes, find out what your team likes, find out what your ICU likes, how they kind of do things. Maybe they do head to toe. I dislike that. Maybe they do. Maybe they don't. Maybe they do like that. Um, but you want to be able to say, these are the problems. This is what I'm doing to get more information about. This is what I'm doing to actually treat it. This is the plan for the next, 24 hours. For the fact that they have total body hypervolemia. We're monitoring their weights and ins and outs. So we have them on CRT because they're currently anuric. Our goal is to have them 2 liters negative over this 24-hour period. We're monitoring their electrolytes, right? Um, and you want to be able to present through and talk that out. And so this is, a little bit not as thorough as what I would normally present this as because we only have an hour. But the idea is that if you get your entire team on the same page and they can kind of go through this, everybody can communicate with each other efficiently and everyone will know what everyone's talking about and everyone will, be on the same page. That's sort of the goal. I think of one story where I was in the emergency department and we knew a trauma was coming in, and there was a trauma surgeon there who was kind of casually talking, and he's sort of bashing ATLS. He's like, I don't need ATLS. I'm a trained trauma surgeon. I adapt to the situation and I'll do what's necessary. And, that's ATLS is for amateurs. And what I kind of said to him was like, no one denies that you're super trained and you're highly proficient and you can adapt to any situation. But no one knows the rest of your team what's going on in your head. So you're adapting on your own and your team is floundering. The whole idea of ACLS is the nurse knows what's coming next, the PA knows what's coming next, all the techs know what's coming next, and the doctor know what's coming next. And we're all on the same page. We're all on the team together. We have a framework. And within that framework, yeah, the surgeon can express himself and be adaptive and whatever. But if you're going to have a cohesive team, you need a way. You need a framework if it's going to work, right? Or if it's going to work well. And so, someone might see this and be like, this is anal, this is ridiculous, this is overkill, this is too detailed. Um, it's a framework, it's a starting point, and it's a way we can jump forward. So that's the short of it. I hope it was helpful. The rest of the month will be similar as far as this is meant to be like a basic introductory type month to clinical practice. I hope it was helpful for you. It's meant to be kind of general. So I think that's it. I'm going to go back to bed now. Have a good one.